Okay.
Okay, so we're going to start. When it's over, it's not over. So if you're in my field, you have a lot of uh, pregnancy complications. Sometimes you're just happy to get the woman to a gestational age where she and her baby can do well, and you're relieved that things have gone well. But when it's over, it's not over when we're talking about hypertensive disease of pregnancy. And so today we're going to define what the disorders of hypertensive disorders are of pregnancy, discuss the postpartum and long-term complications of those pregnancy complications, as well as the postpartum and long-term management strategies that are necessary with women with hypertensive disorders of pregnancy. Um, First, we'll do is define chronic hypertension. So hypertension for the American College of OB-GYN is defined as hypertension before pregnancy or less than 20 weeks of gestation. With ACOG, or the American College of OB-GYN, that's defined as a blood pressure greater than 140 over 90 millimeters of mercury. During pregnancy, you may be aware that the American College of Cardiology and the American Heart Association a few years ago changed the definition of hypertension, with normal being less than 120 over 80 millimeters of mercury. That's not how it was when I was going through medical school. And that elevated blood pressures are anywhere from 120 to 129 over 80 millimeters of mercury, with stage one hypertension, 130 to 139 over 80 to 89. And then stage two hypertension being that 140 over 90 millimeter range. American College of OB-GYN has not changed our definition yet or perhaps will not with further studies. But so for in pregnancy, hypertension is defined as still that 140 over 90 millimeters of mercury. Gestational hypertension is hypertension diagnosed in pregnancy, typically after that 20-week period, in the absence of proteinuria or protein in the urine. Preeclampsia is defined as hypertension and proteinuria, with proteinuria being defined as greater than 300 milligrams of protein in a 24-hour period, or a PC ratio of 0.3, and or end organ dysfunction. There are severe forms and non-severe forms, and they include things like thrombocytopenia, platelet count less than 100, severe persistent headaches, evidence of end organ disease, as well as blood pressures in the 160 over 110 millimeter of mercury range. And then HELP syndrome to me is just a variant of preeclampsia, but it's hemolysis, elevated liver enzymes, and low platelets. And eclampsia is where the patient actually seizes a new onset seizure in the absence of some other known seizure disorder. That's preeclampsia until proven otherwise. We know that there's a very good link between preeclampsia and cardiovascular disease later in life, anywhere from a 2 to 4-fold increase in the risk of heart failure, myocardial infarction, coronary artery disease, stroke, or even death due to hypertensive diseases of pregnancy. And that risk is even further increased if there's severe disease, meeting those severe criteria, as well as early onset disease, meaning it happens before 32 weeks gestation, or recurrent disease. You've had preeclampsia in more than one pregnancy. The mechanism isn't well understood. Which came first, the cardiovascular disease or the preeclampsia? There's certainly hypotheses that the presence, they share similar risk factors for both preeclampsia and cardiovascular disease, such as hypertension or diabetes. There's a common pathophysiological process leading to both. Did the preeclampsia reveal or cause some lasting endothelial dysfunction that later leads to cardiovascular disease, or did it just reveal that this is a patient who is at risk for cardiovascular disease later in life? Or is there some combination of the two together? So once we've gotten that patient all the way through pregnancy, we delivered her and her baby. We want to manage her appropriately if she's had hypertensive disease of pregnancy. And one of the first things we want to do is manage her blood pressures. And that may require treating her with an antihypertensive. ACOG suggests maintaining the blood pressure less than 150 over 100 millimeters of mercury, but the initiation and treatment should be individualized and based on clinical judgment. For example, if you have a patient who already has renal compromise or has cardiac compromise, you may want to maintain her blood pressure at a lower level. And there may be nuances about different medications that you use, and you may individualize that certainly for each patient. Home blood pressure monitoring is certainly recommended, and you want to titrate the medication as those hormones of pregnancy leave her system. Maybe her blood pressure will be adequately controlled without medication or on lower doses of medication. So it's very important to monitor and follow. There's no standardized management, and the guidelines are for specific agents or parameters are individualized. Women in our system are typically discharged anywhere from 2 to 4 days postpartum. The American College of OB/GYN recommends that a single blood pressure check occur between 3 and 10 days postpartum for any patient with hypertensive disease of pregnancy. And women with persistent hypertension or other concerns are typically seen more frequently in that initial period postpartum and typically seen again at 4 to 6 weeks, as well as may extend anywhere out to 12-week visit with the new American College of OB/GYN guidelines. Then we want to make sure we have a good handoff, a good transition to a long-term provider. So in that immediate postpartum period, right after delivery, we want to have adequate control. Again, American College of OB/GYN suggests using a blood pressure of 150 over 100 for that adequate management. You may recall that severe disease is a blood pressure of 160 over 110. We definitely want it lower than that. Do we want it down to 120 over 80? Maybe not immediately postpartum. So that's still debatable, but we want it at least lower than 150 over 100 in most cases. We want to educate the patient. Education is important. Knowledge is power. We want to tell them about the warning symptoms of preeclampsia. Just because they go home, maybe they just had gestational hypertension. They haven't been defined as preeclampsia. You want to give them those warning signs. Patients can certainly present postpartum with their initial complaints of preeclampsia, and as well as patients have presented with seizures postpartum that didn't seem to have any signs or symptoms of preeclampsia while they were pregnant. We also want to make them aware of the symptoms of cardiac compromise, such as chest pain or shortness of breath or leg swelling. And if you've taken care of pregnant women, you know that oftentimes they may complain of chest pain, epigastric discomfort. They might have shortness of breath and leg swelling. So it can be a challenging thing to figure out, but we don't want to dismiss any symptoms that a patient is presenting to us because that can be very compromising for the patient. We want to discuss that they're at increased risk of developing preeclampsia and subsequent pregnancies. We want to suggest to them that they should be seeing a doctor on a regular basis in between pregnancies and having their blood pressure managed, but also when they do get pregnant to see their OB/GYN doctor or their provider as early as possible. Low dose aspirin beginning at 12 to 16 weeks ideally is important in helping to reduce the risk of preeclampsia and subsequent pregnancies. We also want to discuss the long-term risks of cardiovascular disease that may not occur in the first year, it may not occur in the first decade. It may occur some 17 to 20 years after delivery, but that patient is at risk and she needs to be made aware of those risks and to monitor her health appropriately. And then we also want to provide appropriate contraception to reduce the risk of a subsequent pregnancy that puts her at risk until she's ready to have that pregnancy. So oftentimes, particularly if you work in a system like mine, there's lots of layers to the system. You want to provide the patient and her provider with the appropriate information for follow-up evaluation. That contact information should go to the referring provider and all people involved in her care. We want to somehow figure out how to get a blood pressure done in 3 to 10 days, according to the ACOG guidelines. And that might be through telehealth, through clinic visits, and might see her in the NICU and have her blood pressure monitored, or through her pediatric care provider, if there's a good system where we're all connected and communicating with each other, as well as the OB, the obstetrician's office. and definitely discuss the need for long-term follow-up. When it's over, it's not over. So if you're in a system like mine, we're seeing the light and how we used to think it was going to be great to be siloed, and that we have neurology in that building over there, cardiology in that building over there, OB in this building, and we're learning that that's not patients aren't really divided into those things when they have obstetrical needs, and so it's nice that we can all hopefully be together in one adult healthcare system where we can easily access each other. And so if you are in transitioning like we are, the care is often fragmented and siloed, and we want to make sure there's good follow-up and communication. We want to counsel the patient on the risk and the importance of long-term follow-up. And we want to begin that conversation in the hospital before she leaves the hospital. Unfortunately, 40 to 60% of patients don't return for postpartum, their postpartum visits. That might be related to post-traumatic stress. Maybe their baby didn't do well. Maybe they had a traumatic delivery. Maybe they can't stand the thought of walking back into that hospital for a follow-up. We need to make sure we get some type of follow-up and assistance for all those concerns that they may have. They may have transportation issues. I have to ride 2 or 3 buses. There is no bus line. I can't drive. I had a C-section, etc. Their work issues. I've been off work. I've been in your hospital for 3 weeks waiting for a delivery, and now I need to get back to work because I'm the primary care provider for our family. There may be child care issues or other issues. We have to help address all these issues to make sure we get the appropriate care. As I said, that increased occurrence of cardiovascular disease may occur within the first year, but it may not occur until 1 or 2 decades later. And certainly reports up to 17 years after delivery have been reported. Those risks possibly may be mitigated with lifestyle changes and treatment, and we certainly ought to try. And we're certainly investigating what is the best way and the best way to monitor and what do we do. But until then, knowledge is power, and we know that exercise and diet can help reduce the risk of cardiovascular disease for those who are at risk. We know that sometimes medications, if we need to control their blood pressure, if we have lipid abnormalities, to have the appropriate follow-up for those patients. Smoking cessation, why add some other factor to it when we know you're already at risk? And so if a patient knows they may be at risk and we discuss those risks and why we're recommending that they stay in contact with these adjunct providers to help maximize their health care, they're more likely to do it. Again, knowledge is power. Education is important. We want to counsel the patient regarding the increased risk for cardiovascular disease and the need for coordinated long-term follow-up. That coordinated follow-up may provide improved healthcare and wellness between pregnancies. I can't tell you how many patients come back to me and say, when I ask them about hypertension, they said, yeah, I had it in my last pregnancy. Well, did you have it in between? No. Did you go to a doctor and have your blood pressure checked? No. So you don't know if you had high blood pressure. I don't know what the compromise has been, if it's been there, but certainly we've identified it now. But if we educate patients, at least if we do the benefit of telling them why we want them to make sure they have follow-up, that certainly can help. It can improve their health outcomes with subsequent pregnancies and reduce their risk of long-term cardiovascular disease. As I said before, the mechanism of why they're at risk is not well understood. Which came first, the cardiovascular disease and the pregnancy just revealed their risk factor for it, or did the preeclampsia cause some kind of complication that predisposes them to cardiovascular disease? Pregnancy can be looked upon as a cardiac stress test. It's a lot to carry around an extra human being and the life support that it requires in your body, as well as any other complications that may occur during that pregnancy. And I think I already talked about those risks that might lead to it. So we I think there's an opportunity to optimize care and long-term follow-up in pregnant women. I think sometimes one of the most important things in pregnancy, when I see patients, when they come to my level, that I can do is educate them on their long-term risks and what they can do to be around in the future for their children, that baby that they're carrying now or in the future, whether that's gestational diabetes and their increased risk or hypertensive disease of pregnancy. But the better you are, the better you are, and the better we can help women to be and men and their families. And moms often lead the welfare of their families. And so the better we educate them about the importance of exercise, nutrition, and good health, the better that whole family will be. So hypertensive disorders of pregnancies, I believe, are an opportunity to identify women at increased risk for cardiovascular disease that will improve future pregnancy outcomes, improve their long-term cardiovascular health, optimize their cardiac health after delivery, and may provide a benefit where they don't have those that cardiovascular event some 1 to 17 years later. The American Heart Association actually recommends that all women be questioned about their obstetrical history as a screening factor for cardiovascular disease. And I hope that we continue to have the opportunity to optimize long-term health outcomes. With the expansion of Medicaid to 6 to 12 months insurance, we currently have that in our state, and there I think most states have had it. We'll see what happens to Medicaid as we move forward, but it can provide an opportunity to obtain some baseline studies for women who may not have insurance a year from now. So if you have a patient that had preeclampsia who's complaining of shortness of breath and has edema, shortness of breath and edema are an indication for a maternal echo. And so you could get a baseline echo that might identify this woman is more at risk for having cardiovascular disease later on in pregnancy. This is somebody I want to get in to see a cardiologist this year while she still has insurance so that when she needs follow up, there are some baseline studies. They may want to do some lipid studies and other things on these patients that further help identify their risks. But it's not quite clear whether baseline cardiovascular studies help prevent or will treat that. We're still looking at all factors that may improve outcomes, but I have to believe that it helps to have the more data we have, the more knowledge we have. And that if we identify something now that's at risk, if we don't optimize it, that's certainly going to be further risks down the road. So whether those patients need an echocardiogram, a cardiac MRI, whether they can evaluate structural or functional cardiac changes remains to be identified. I believe that it could be a benefit to have that while a woman has insurance, while she's in that first relative immediate postpartum period. And it may be a way to help us later on to differentiate who really benefits from close surveillance and more aggressive management when they have hypertensive disease of pregnancy. But certainly further study is needed. Well, as I said before, there 40 to 60% of women don't return for their postpartum checks. And if you ever had a baby, I can sort of understand it. It's a challenge, but it's important and if you add any other layer of obstacle to it, it may be further a challenge. Um, and attendance rates may be lowest for the populations who are most at risk with limited resources. As I said before, the factors that may contribute to the lack of follow-up and outcome include work and transportation and insurance issues, those social determinants of health that can affect outcomes, post-traumatic stress disorder, poor communication between the hospital provider and the primary provider. I tell the residents all the time, communication is important in any relationship, whether that's marriage or medicine, and make sure that we communicate with people. When you're in a system like mine, there's lots of layers, unfortunately. The patient may only be there in our hospital for her delivery. And we need to make sure we have good communication back to the referring provider through as well as with the patient and any other providers that are needed. We need to make sure that the patient understands the importance of the follow-up. And we need to stress that because when you just had a baby and had maybe a traumatic delivery or an unconventional delivery, the one you didn't expect, you may not be listening to everything that they're saying right away. So we want to repeat those messages so they understand that. Babies who are in the NICU and the mom's returning to the nursery all the time, she's traveling back and forth. She may choose that OB visit is not as important as me going to see my baby who may be on a tenuous lifeline right now, and I want to make sure I'm there with my baby. Maybe having the ability to walk across the hall and get your blood pressure checked or checked right in the NICU, as I know some systems have, is a benefit to patients in those situations. Some studies also suggest that better follow-up occurs with technology, whether we have remote home monitoring, phone apps, text messaging, things that we can use to help prompt and encourage those women to have the appropriate follow-up. And then we want to make sure that our follow-up is coordinated. One of the things we always typically talk about is contraception. What do we do to prevent pregnancy? Hopefully, that conversation has started way back in her obstetrical care before she delivers. And who will provide the care and the follow-up? If you're in a system like that, sometimes it's confusing to the patient. Do I come back to you? I've been seeing you for 3 months, or I've been in the hospital for weeks and weeks and weeks. Do I go back to you or to my primary provider? I'm here. Sometimes we get referrals from all over the state. So maybe I live 3 hours away, but I'm staying here because my baby's in the NICU. Who do I follow up with? We need to make sure there's good systems and understandings for that so that the patient is not left wondering or at a deficit. We want to have education and services, home blood pressure monitoring, dietary and nutritional counseling. I think everybody could benefit from dietary and nutritional counseling, whether they're pregnant, non-pregnant, male or female. Weight loss counseling, visiting nurse, telehealth services, and then the appropriate referrals to cardiology or nephrology or anybody who needs to be involved, depending on what complications were noted with the patient's pregnancy and her delivery. As again, I mentioned before that some patients, their insurance coverage may expire in 60 days or sometimes within the year, and we want to optimize what we can while they have the insurance coverage to cover it. So anybody who knows me knows that I'm all about team. It's hard to beat a good team. And these are just some of the people I keep adding to the list that I think are important for a team taking care of a woman and her family when she's and her newborn baby when she's had a hypertensive complication of pregnancy. I think the maternal fetal medicine specialist is at the bottom and the lowest on the totem pole as far as the care postpartum. We want to make sure we have good communication with anybody who needs to be involved, which might be the obstetrician. Doulas are awesome and very helpful in those regards. Midwife, family practice physician, internist, or cardiologist who can help with those as needed. The social worker is key. Therapists, telehealth medicine, and nutrition and dietary, but also pediatrics. A woman often, that 2 days after your baby delivers and you go see the pediatrician, you'll see the pediatrician often before you see your OB. And so they can be very key in helping to identify a lot of complications, including postpartum depression and other things for pregnant women who have gone through a non-completely normal delivery. So in summary, there are increased risk of long-term cardiovascular disease in women with hypertensive disorders of pregnancy. Many questions are unanswered regarding management and the reduction of long-term risk, cohesive transition, communication, and a good handoff of care from the OB system to the long-term providers is critical. Education, 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 communication, communication, communication about the future risk is important. Lifestyle changes and optimal treatment may help reduce the risks and improve the long-term outcomes. Thank you.